This session is about patient-centered care. Patient-centered care. I have one child. Everything seemed to be going fine with him until he was about 16. Started complaining of a lot of belly pain and brought him into the doctors. And ultimately, he was diagnosed with an inflammatory condition of his bowel, Crohn's disease for what it's worth. And one of his visits to the hospital, and keep in mind, this is the hospital I work at. One of the GI specialists came in, sat down across the room at a computer, started asking questions, looking at the computer screen and typing in his note the whole time. Never once did he come up, walk over to my son, examine my son in any way. Nothing personal about it. We all may have different definitions of what patient-centered care is, but I'm pretty sure that's not it. It happens to all of us. I think at its core, patient-centered care really focuses on what the patient and the patient's family needs and wants, now and in the long term, what matters to them, not to us as the doctors. I think one of the impediments to this has been our assumption, as doctors, that we know what patients want. As you know, every patient is different. Every child is different. And I really do think it starts with engaging our patients in an open dialogue with them, really talking to them. It's funny that we often think that patients will bring stuff up. Like if it's important to them, they will bring it up. But you know, they don't often. And I've pondered that, why, if it's so important, why don't they ask me? And I'm convinced that many times we, all of us as patients, feel that if we bring it up, it makes it real and it's scary. So we don't ask. It's almost safer to not ask those hard questions. With Cleft, as surgeons, we're so often focused on the scar or on speech analysis. What was brought to my attention by our next speaker, Dr. Laura Monson, is that it is not always really what families are most concerned about. As you know, it's so often these things like, will my child be able to make friends? Will my child find somebody to spend their lives with? Are these kids happy with their lives? Those of you here today who've had a cleft or a child with a cleft can appreciate the questions or concerns that probably went through your mind that were never addressed by those people that cared for you or your child. And so often, part of the reason why meetings like this are so important is that cleft-affected children often never get to spend time with other cleft-affected children. And that's something that is so incredibly powerful. We don't perceive it as doctors, right? Because we're seeing these kids all day long. But so often, that child is ushered into a room, seen by a doctor, and ushered out, never having had a chance to interact with another child. It's things like this involving patient-centered care that Dr. Monson has been so involved in addressing at our institution here at Texas Children's Hospital. Just by way of brief introduction, Dr. Monson is somebody that was recruited by me to the faculty at Baylor and Texas Children's about 12 years ago. She completed her plastic surgery training at the University of Michigan and her fellowship in cleft and craniofacial surgery at the University of Pittsburgh, the Children's Hospital there. In her current role, she serves as Associate Professor of Plastic Surgery, co-director of our craniofacial clinic, and as the Chief Quality Officer for the entire Texas Children's Hospital system. Please join me in welcoming Dr. Laura Monson. Laura.
Well, good morning, everyone. And I think Dr. Ole actually just gave my whole talk. But I'm going to try to expound on this a little bit and talk about an evolution of Cleft Care to a team-based, patient-centered approach. And I'm just going to give the caveat that this is a work in progress, and it will always be a work in progress because the needs of our patients and families change with time. They change as social media becomes more prevalent, they change as kids get older, and they change as our health system evolves. And so we are continuing to improve, and this is a little bit about how I started in my journey of quality improvement without really recognizing it. And so, like Dr. Hollier said, I started here 12 years ago, but before that, it was obviously high school, 4 years of undergrad, 4 years of medical school, 7 years of plastic surgery residency that required basic science research as well, and then another year of fellowship at these wonderful, beautiful institutions where I was trained to do surgery in a very traditional manner. And for those of you who haven't done a surgical residency or fellowship, it's maybe a little bit different than what you might imagine. We are trained to really revere some of our pioneers in surgery. And we're taught that to be an amazing surgeon, your name needs to be on something. There needs to be a surgery that's named after you. There needs to be your name in the textbooks. You should have an instrument that's named after you. And this is sort of what is taught, that that's what it means to be an amazing surgeon, to be that person that everybody sort of reveres and follows how they did things. This is Dr. Leonard Furlow. He is the person who designed one of the palate repairs that many of us do these days, and he designed it actually at a conference back in 1976, and there's sort of all these wonderful tales about how they were at this conference and they were yelling and debating about how you should really do the surgery. There's a lot of arguing among surgeons, by the way, about who's right. And he actually initially sketched it out on a cocktail napkin, how he thought it should be done. And so this is kind of what we're taught to look up to and who we're supposed to emulate as we become full grown-up surgeons of our own. And then we go to these meetings and you're kind of drilled into that when you become a cleft surgeon, you want your patients to, after surgery, look like they've never had a cleft. And that's what it means to be truly a great surgeon. And we argue a lot about how to measure the differences between the picture on the left and the picture on the right, and which one of us is right. And it's about, microns and millimeters. And that's kind of how I had trained for 8 years, about being able to draw this out perfectly. You get quizzed on this before you can fully get your license in front of lots of people. And these are all drawings in like small millimeters. And this is what we kind of quiz our residents. Can you draw it? Can you draw it at 4 a.m.? Can you draw it at 2 a.m.? Can you draw it after you've been up for 24 hours? And that was sort of our initial training. And then I became a faculty, and I met a couple patients very early on in my career, and this was one of them. And this is a lovely young lady who had been taken care of at our institution, but she had missed a couple of sort of key points in her care, and was really struggling as a teenager as she was going through high school. And she started to ask questions that I really couldn't answer about why it was that her outcomes were different, but they weren't about the outcomes that I had been trained to think about and look at. And then I met a few mothers and grandmothers who also asked some very poignant questions that had nothing to do with whether they were going to have a pushback palatoplasty or a furlough palatoplasty or a Mulliken repair or a Randall repair, because they didn't care about any of that. They cared about how their baby was going to be as a child, as a teenager, and as an adult. And for them, quality of life was so much more important than what the name of that particular surgery was going to be. And so I started to rethink what it meant to be a good surgeon for my patients and families with a few of those early interactions. And I looked at what we were evaluating as we put together papers and presented research. And this was really, at the time, how we evaluated our surgeries. And nowhere in here was there any input from our families. None of this was what they were asking me about. And we had never asked them what was important to them. And so we kind of went back to the drawing board as a team and thought about rebuilding our team with a different shared vision. And it became a much less egocentric place and a much more of a team-based mentality. It's still in progress. We still continue to work on this. But we said from the get-go, we want to provide excellent clinical care, provide excellent family care, and demonstrate an improvement in our outcomes. Not just the outcomes that we had traditionally looked at, but the outcomes that were important to our family. And this is something that you cannot do as an individual surgeon. Nobody is going to name this after any of us, and nor should they. But we had to realign our priorities with the priorities of our families. And so we had a lot of wonderful things, but we wanted more. And I apologize, nutritionists got left off at the bottom of this slide, but Jasmine is a very important member of our team. But in order to provide that whole care to our families, we needed more than just the surgeons. We needed all the rest of these people, and not the way we did it when I was a resident, where we all kind of walked in and we stood over the family and we pointed at the baby and they would lecture the medical students and we would ask them questions to see if they got the answer right or not in front of the family and in front of the child. We wanted to do this in a way that was much more sensitive than that traditional model. And so we worked slowly. We got support from our hospital in order to incorporate the rest of the team members that our families needed. What I found as I went through this is this actually really well lines up with the Institutes of Medicine and what they consider core components of quality from the patient's perspective. And this is a national model that many people that work in quality improvement in health systems look at. And this is something that I include in every talk that I give to our hospital administrators as we start out whatever that talk may be about. This is the first slide that they see. And it's about that patient and family at the center. And what is most important to our families? Obviously, it's to keep them safe. It's to help them stay well, to help them navigate their care in a timely and efficient manner, to treat them with respect in an equitable and patient-centered fashion, and provide them with the right care at the right time. And so, even though I didn't realize the Institutes of Medicine had already outlined this for us, that would have been easier. We figured it out on our own, that this is the right thing to do. And it's to keep the family and what they want at the forefront. And so we've tried to ask the right questions for the last 12 years. And some of them we got right and some of them we got wrong. We've done a lot of different things. But we started with some surveys with our families. And what they initially said was that they were looking for patient and family support groups. And so we started down at the Meyer building on Saturday mornings, bringing in our speech pathologist or our social worker or our psychologist, and inviting our families to come, ask questions. And then eventually it became me and a box of donuts and nobody showed up because everybody was finding each other on social media, which was great. A lot of donuts. We've also tried to do this in clinic in the break between morning and afternoon session to provide lunch and have families meet each other. But then again, it seemed like a lot of our families and parents were finding each other on social media and didn't necessarily want to meet in person. And then the pandemic really shifted everyone more online. And it might be swinging back now. We've heard, obviously, through this session that people do want to see each other in person and have a little bit more of that connection. We've tried to outline a little passport that's kind of like your kid's vaccine card about making sure that they hit those milestones. These got lost. We've transitioned to an online version. This is something else that's still in progress. At the same time, things were changing throughout the country and how people were delivering healthcare. And I think the newer generation of surgeons and physicians feel we like to work in a team, maybe a lot more than previous generations had, and we're a lot more collaborative. In the past, it would be a single center institution just publishing sort of their data and their outcomes. And over certainly the last 10 years, people have started to share data much more widely and realize the only way to get to the right answers is to ask the right questions, but to do this as a group. And so I worked with this group. It's an international consortium on health outcomes management. Cleft was one of the, it was the first pediatric condition that they looked at. And this was Saturday mornings, myself, our speech pathologist, our orthodontist, and people from all over the country, patients, families, parents, trying to agree on what we should even look at. And this took 6 months. It is an amazing piece of work, and we have never been able to implement it because it is so cumbersome. And none of the children's hospitals have been able to implement the entire bundle, but we've done parts of it that we've been able to implement in our own clinic. Things that are important to our families in this area that we care for with the resources that we have. But this was the first time I've really worked with patients and families in a very organized structure to ask the right questions about what was important to them. And it's wonderful. This ICHOM group has a meeting every year in Boston. They look at lots of various conditions in the adult and pediatric populations. And that, at the same time, came out what's called the PROMISE questionnaires, which allowed the clinicians to really try to understand the patient's lived experience across physical, mental, and social health. And then these became much more implemented in our clinics as well. We also instituted our ERAS protocols. This is from a friend of mine at work. It's not this kind of ERAS, not ERAS, it's ERAS. It's Enhanced Recovery After Surgery. And these became really popular at the same time. And this is really about trying to minimize the impact of any surgery to the child, to get them back to their normal state of health as quickly as possible. And again, these tools and protocols we put together from children's hospitals across the country for the first time, really working together and looking at, oh, your length of stay is lower than ours. What are you doing from a pain management perspective? How is your anesthesiologist managing, the different cocktails so kids aren't waking up nauseous, and really starting to share data from the things that we could control to get kids back to their baseline as quickly as possible. And these have been very rewarding for many of us to work on, because especially for our bone graft age kids, that surgery is the first one they remember. And so if we can make it as easy as possible for them, they'll be much happier to come back to clinic and interact with us afterwards. So we learned a lot of lessons through all of these endeavors that we thought were important for our care team, but we also learned a lot of lessons for our family. And one of the things that I borrowed this from one of our neurosurgeons, he and I talk about this a lot, and it's about bringing the service component back to the patient and family-centered care. All of us went into medicine to give back and do better, and to really try to impact people for good. And sometimes that seems like it gets lost when you work in a big institution or you work in healthcare in this day and age. But if you can bring back that component of the hospitality and service, make your patients feel seen and heard and cared for, it brings back so much, not just to the family and to the patient, but to the provider. And it turns what can sometimes be a job into a much more rewarding service, which I think is what we were all after when we started down this path. This is a wonderful book about the transforming power of hospitality in Cleft Care that we've tried to implement at least Personally, I've tried to implement it in how I care for my families and my patients, but making sure that your family feels that they are always at the center of what we're doing, I think is sort of the next step in evolution of how we deliver healthcare in this country. Because, I don't know if you've heard, we have a problem with burnout. And what we found is that the more engaged we are with our families one-on-one, the less we're looking at that computer, the more we can focus on that relationship, the more we get out of it as providers as well, because we're here, we show up to work every day to try to help people be better, to help improve their situation. But when we lose that connection, it can sometimes lead to burnout among our team members. And so bringing us back to that patient and remembering why we're here. It's not just the right thing to do for them, it's the right thing to do for our care teams. This is a young lady that we kind of had as part of a pilot that we're doing of some advanced orthodontics to try to improve jaw discrepancy and sort of the alignment of the bite as we go through middle school, to try to avoid that big jaw surgery in our teenage years, or to at least make things better as we get through middle school. And her family and several others have been really happy with that treatment, but trying to push those boundaries and think about things differently than how we were taught when it was you always had to wait until they're fully grown before you could do anything. Well, maybe not. Maybe we can do something to make middle school better, to try to help them so that they can eat the things they want more easily. And so thinking about that when our patients tell us that that's what bothers them, it's eating at the lunch table when they can't bite into a hot dog. How can we make that better? How can we think about that differently? And that's really about asking the right questions and having engaged care teams to lead to those better outcomes. From this, we heard from our kids that a lot of them came to clinic and they might see somebody in the waiting room, but they didn't know anybody at their school that had a cleft, and they didn't really have anybody else to talk to, especially in those tough years through middle school and high school. And that's why we started our Cleft Camp for our teenage kids, as just a chance for them to socialize with each other, and for us to have a really great fun weekend with our patients outside of the hospital. Between wall climbing and ropes courses and canoeing and all the fun things that we get to do at camp, it has been a wonderful way to recharge our team, but also a way for our kids to connect. I cannot tell you how many prom dates came out of some of these camps. But I loved getting their pictures. It was fantastic. And so this became our support group for a while. We had to close it down during COVID, but it will be back. And it's been really important for our whole team. And that's the last thing I wanted to say is about asking better questions and getting better answers. It's about having a little bit more diversity in that care team. This picture at the top is from my residency way back in the day. The lovely lady in the middle was graduating that year. All those dudes in black are my co-residents and attendings. Emily and I were the only two female residents for 7 years. Until the year she graduated. And then the lovely ladies in green and purple joined me the year she left, and we had one solo female attending. And it was kind of lonely sometimes, but when those are the people asking all the questions, you get a certain set of answers. Unlike this group here, which was taken last week here at Baylor, these are our current crop of residents and attendings. And I just think the more diverse care team you have, the more diverse questions you ask, you get much better answers that get closer. It's not perfect, but it's getting closer to the right answers for our family.